Okay. Now, everybody, we'll get started again. And before we commence with Dr. Deirdre Lundy's talk, we have Dr. Maeve Crowley, who's a haematologist in Cork, just wants to make a little appeal to you. Maybe you can help her. There you go.
Thanks very much, Anne-Marie, for just giving me this time. So I'm a consultant in Cork University Hospital, and as part of International Partners, we're taking part in a clinical trial. And what this is looking at setting patient-focused outcomes for VTE research, so that in the future, if we're looking at a new anticoagulant or new stockings or any new treatment, that when we're doing the trial, that we have things that are important to patients. Because at the moment, they're very kind of doctor, scientist-led outcomes. And kind of, we look at things like another clot, bleeding, things like that. But that's not always what's important to people who have blood clots. So that's what we're trying to look at in this study. And we're going to do it all around the world. Ireland is the second country to open in the world, with Canada, who are leading on the project. So if you were interested in participating, what it would involve is kind of a 30 to 60 minute interview. That can be done in person if you live in Cork, or over Zoom or on the phone. We can work around it. There's no right answers or wrong answers. It's just about your experience and kind of the problems you've had with your treatment, or the things that you found good, or what you think are important from your point of view. Because I think what we really want is patient outcomes, because I think that's where all kind of things are going. Because that's why you go on treatment, to improve your life, not my life. So you should be setting at least some of the outcomes. So just a little appeal. If you're interested, Anne-Marie has all my details, and I can give you a call or send you some information if you were interested in learning a bit more about it. Thank you very much.
So thanks. So really, it's just if you wanted to have your say and maybe, get involved in research. Yes, I've actually done it, and it takes about it took about less than an hour over the phone, just to answer a few questions and just give your say. So it'd be fantastic if a few of you would volunteer. So now we've got the amazing Dr. Deirdre Lundy. Deirdre has been working within general practice, but specialising in women's health for over 35 years. She's originally from the USA, but attended UCD Medical School and never went back. She's worked for all the various family planning clinics around Dublin, and was a member of Bray Women's Health Centre for more than 20 years. I think I'll leave it at that. That's enough.
Thank you very much, Anne-Marie. Thanks a million. Thank you for allowing me to take some of your time. I appreciate that not everybody in this room is going to be as engaged about menopause as everybody else, but presumably you know females, and you might be related to some of them or married to some of them, so maybe some of this would be of interest to you in the future. Those are my declarations. And I'm going to start by saying that Anne-Marie and I just had a throwaway conversation before I started, and it's actually kind of made me really kind of irritated, because we've gone to a lot of trouble to get really good evidence-based information available for patients, females going through menopause who may have experienced venous thromboembolism in the past, what the rules are and what their choices are. And unfortunately, it doesn't always seem to, you can sometimes get conflicting advice from your hematologist. And that is absolutely undermining. Unless we're all on the same page, there's no point me telling you these are the rules, this is the good information, when you go back to the person who supervises your hematology medication to be told completely inaccurate information. So the room I need to be in front of is not ye, it's hematologists. So do call me, Anne-Marie, when that opportunity arises. I'd be very, very happy. So very quickly, some background information, stuff you already know, and these slides will be available for you at your own time. So excuse me for booming through, but I want to get to the important part stuff. So the ovaries are the core of menopause. Our ovaries produce our ova, our eggs, so that we can get pregnant, have periods. But they're also the source of a lot of essential sex hormone. The three main ones that we rely on during our reproductive life are estrogen, progestogen, and androgens. We actually have 3 different estrogens, 1 progesterone, and 4 different types of androgens. So women have more numbers of male hormone than they do female hormone coming out of them, but in very, very small doses now, in fairness. From puberty to midlife, our relationships with our sex organs are the same, male and female. They start to create hormone during puberty. You eventually get to a kind of an even place after 16 to 21, going through sort of a disruptive hormonal time in your life. But for males, that carries on until you die. For females, it's a completely different story. For reasons we're not 100% sure of, there's a built-in obsolescence to ovaries. And from around 45, 50, they start to pack it in. Now, some people would be very grateful for the loss of fertility and the lack of having to deal with bleeding every month and the pain that goes with it. But unfortunately, when we lose our ovarian function, we don't just lose eggs, we lose those essential female hormones. And our levels, by the time we reach 55, 60, are unmeasurable. So it's like as if we've been castrated in midlife. And yet, unlike males, we're supposed to continue in the workplace, continue doing our lives, be the same people we always were, and that's virtually impossible for some people. 80% of women, females in the developed world, have significant symptoms during this transitional phase of their life. These are the physical symptoms. People trivialize sweating and flushing, like as if, well, I sweat when I run or jump up and down or go up the stairs. That's not that big a deal. 20, 25 times a day, standing in front of a room, giving a lecture, 5, 10 times during the night, waking you up from a sound sleep. It is one of the most disruptive symptoms of the menopause phase of your life. Periods can go wonky. Everything that relies on collagen tends to decline, so your skin, your hair, your nails, the texture of your vagina, the moisture that the vagina creates. The bones and the joints can become an issue when you go through the menopause. Your metabolism is driven in females by estrogen. So when estrogen levels falter initially and then decline, you don't burn calories the way you once did. And most Western females will gain between 1 to 2 stones between their 45th and their 55th birthdays if they don't change the way they eat or change the way they exercise. And that's entirely to do with estrogen deprivation. And obviously, if you've already got sort of medical issues to juggle, you do not want excess weight on top of that. These are the psychological symptoms that are related to estrogen faltering and decline. Estrogen is a feel-good hormone. It talks to dopamine, it talks to serotonin, and without it, a lot of women get a lot of emotional disruption. You can get depression, you can get anxiety, irritability, rage. The tiredness can be primary because you don't have your estrogen, but some of it comes from that awful sleep deprivation that the flushes and the sweats create. A lot of people notice that their cognitive ability declines. They're terrified they're going into early dementia and Alzheimer's because words disappear, they lose their focus, their memory starts to lapse, and they think, what the hell is wrong with me? And all it is menopause. Now, for the most part, these symptoms are not permanent. Some of them are. So if you can survive the 7, 8, 9 years of this, there's a good chance that by the time you hit 58, 60, everything will have evened out again. So most people will survive their menopause, but their quality of life will be severely undermined. And that can't be overestimated, When you're still bleeding, so you say you're in your 40s and you start to get episodes of those type of symptoms, it's very common for GP doctors to tell you, well, it can't be the menopause because you're still having periods. So obviously your ovaries haven't run out of eggs, they haven't run out of hormone. And that's not true. Women who still get menstruation can very much get menopause symptoms because initially what happens is the hormone levels jump up and down, and eventually they do drop altogether and your periods stop. We call that perimenopause, okay? The other important thing about women who are still menstruating, who are getting menopause symptoms, is they can get pregnant. And sometimes they don't perceive that they can. They leave off their contraception. And of course, as you well know, if you've suffered from thrombosis, you don't want to get pregnant by accident because it is a significant risk factor. And you want to conceive under supervision so that you're as healthy as you possibly can be for you and your baby. So how do you manage the menopause? Well, some women use hormone replacement therapy. The logic being, if my symptoms are coming from ovary hormone disruption, I will supplement my ovary hormones for a time, smooth out the kinks, feel better again. But it's not a magic wand. It has to be in conjunction with lots of other stuff. And I don't want to waste your time and, sort of patronize you. Anybody who's been through thrombosis episodes knows damn well that you're supposed to look after your general health. So we need to make better food choices. I'm the worst person to talk to you about that. I've been battling overweight, obesity my whole life. I eat crap. So I need to address that. And if you never address it, now is the time to do that. You should move, and you know that's really important for blood circulation. So even if you're not physically fit, you can't climb mountains, I'm leaving here to first get my flu vaccine and then head up the top of the Spink in Glendalough. So hopefully I'll get in before nighttime. But that's my joy, that's my choice. Maybe you don't like that, or maybe you don't want that. That's okay, but you should move, even if it's at the kettle doing the odd couple of squats or whatever, but do not just sit all day. Not only is it a disaster for menopause, clearly a disaster for thrombosis. If you've never smoked, thank the lucky stars that you never did, because stopping smoking, reducing smoking is one of the hardest things a person will ever do. It's easier to kick heroin. And there isn't as much support as there is for heroin addiction. Now, there are studies that show that if you're a smoker and you use nicotine replacement products, your likelihood of good outcome is much, much higher. So anybody you know and love who's smoking, ask them to consider looking at quit thye and talking to their GP maybe or nurse about getting on nicotine replacement. Alcohol intake in Ireland and the UK is higher than pretty much everywhere else in the world. We are the European leaders in binge drinking and alcohol-related disease. 14 units of alcohol a week for a female is not a goal. It's the maximum amount you can take in before you get sick as a result of alcohol intake. So like 0 would probably be a good goal, but somewhere in the middle actually makes a lot of sense. So if you're already medicating your menopause with wine or gins and tonic, please stop doing that and talk to me. I'll try to get you something better. And then have a midlife health check if you have the wherewithal. Get your blood pressure surveyed. Obviously, if you've had thrombosis, that's probably already happening. Get your bloods tested for sugars, lipids, that kind of thing. One thing you shouldn't bother doing, and don't let anybody do for you unless, I don't know, I don't see any reason to do it, is get your hormone levels checked. Hormone levels have no place in menopause diagnosis. We diagnose menopause by the symptoms alone. So unless you're under 40 and you're going through menopause and your periods have stopped, then I will do a lot of blood tests for FSH and estrogen and stuff. But if you're over 40 and you're getting menopause symptoms and you think you're in the change, you are. And that's the diagnosis. So don't let the GPs and nurses put you off just because your bloods might be normal. So these are some of the strategies we use when we meet patients in the clinic who've had thrombosis. We have many patients in our menopause clinic in Hollis Street who've personally suffered VTE, pulmonary emboli. So we talk about lifestyle, comorbidities, that kind of stuff. But usually people are very well managed and informed if they've been through the hematology services. If someone is not interested in or has been had difficulty, shall we say, using hormone products, then there are some non-HRT prescribable medicines that have been shown to be effective against flushes and sweats particularly. So things like oxybutinin, which is an old school anticholinergic drug that's to help people who pee too much, actually reduces flushes and sweats, which is dead handy. Mood drugs like Prozac, Lustril, Cipramil, SSRIs, SNRIs can also significantly help with both mood, obviously, and flushes and sweats. Gabapentin is another one we sometimes use, especially when sleep disruption is key. Cognitive behavioral therapy is essential in menopause. And you don't have to spend 75 euros for 8 sessions of CBT. There's any number of excellent online resources. And why it makes a difference, I think part of it is to do with the experience of menopause and the experience of flushes and sweats can bring with it terrible anxiety. So if you've ever had like a serious medical issue, like a heart attack, a pulmonary embolism, and you start to feel like this suffusion of heat and tingling and sweat rising up your body, culminating at the top of your head, dripping wet, buzzing with, sensation, you might think you're gonna die. So this is just a flush, by the way. So, you nearly kind of have to talk to them and say, oh, hello, flush. I know who you are. You're not going to kill me. And then that's what CBT does. It just helps you cope with the flushes and embrace them for what they are and to not overlay stress on top of them. And lastly, not least, often first, we talk about hormone replacement therapy because HRT is by far the most effective way to get rid of the disruptive symptoms of the menopause. Moreover, it actually helps women who go through menopause much, much younger than they should, people under 40, to keep their heart and their bones and their brains healthy because women who experience menopause too young are at much higher risk of cardiovascular, bone, and brain disease. Now, there's a lot of reasons why people get nervous when we talk about hormones and thrombosis. We all know that you're not allowed to go on the pill if you are high risk for thrombosis, okay? That makes sense. And the reason behind that is because the potent oral estrogens that are in almost all the pills available, and the contraceptive patch and the contraceptive ring, you may not have heard of them, are thrombogenic. They go directly to the liver, where they affect the protein cascade that controls blood clotting. So everybody on the pill is slightly more at risk of a blood clot than people who just use condoms. Why do we bother? Why does anybody go on the pill when we know it's linked to blood clots? Well, we know that the relationship between contraceptive hormones and blood clots is much, much smaller than the relationship between pregnancy and blood clots. So it's a least worst situation. You might say, well, just use condoms and then you don't have... People using condoms get pregnant 15 times out of 100 every year, so they're not that reliable. So we try to use a reliable contraceptive because our goal here is to control pregnancy for people who are high risk for thrombosis. So for the last 61 years, since Professor Rock invented the contraceptive pill, and all those poor Puerto Rican women in the phase 2 trials were dropping like flies from pulmonary emboli, entirely caused by the doctors and the study. People are terrified of contraceptive hormones, female hormone. They link them to blood clot creation. And it's done a lot of damage because we now know that certain types of female hormone, particularly the hormones that come in modern HRT, are neutral. They don't affect blood clot risk. But that kind of bad publicity lingers. And there are many GPs, many hematologists that don't seem to be aware of the data that supports the use of quality, non-oral, gentle estrogens for menopausal women, and that they have no impact on their personal risk of venous thromboembolism, even if they've had a clot in the past, you know? So you need to be very, very careful about who you talk to because you're not always getting the best quality information. And there can be a sort of a patriarchal type of patronizing attitude in healthcare. I'll be the first to confess that. I don't think that has any legs anymore. That this is 2022. We don't get away with that crap no more. But you know, not everybody read the book. So yeah, exactly. So contraception, the pill, the patch, the ring, absolutely. Be ultra careful. You shouldn't use it at all. And none of your daughters, sisters, whatever should. Because if you've, unless you have a provoked clot, you know, something came along like a pelvic surgery or whatever. But if you've had an unprovoked blood clot, you may have a gene, in which case your sisters, your daughters, your nieces might do too. So that's something they need to be aware of. Does that mean that they just don't have sex? Of course not. They can use non-estrogen contraceptives like all the LARC contraceptives. The bar, the intrauterine devices that you put inside, none of them have any impact on clot risk. And we see a lot of patients in Hollis Street. I run a coil clinic, and I put in intrauterine devices constantly for women on anticoagulation, because if you're on an anticoagulant, a NOAC, warfarin, heparin, your periods are going to get crazy. So I'm forever putting Mirainas into people on NOACs, DOACs, to keep them from bleeding to death as a result of their hematology intervention, you know? So from a HRT point of view, the big thing is you need to avoid the pills. So when you go on modern HRT, a lot of people do take tablets because they're slim, they're not smoking, they're active, and they have no high risk for venous thromboembolism. So HRT tablets are very popular, they're very safe and healthy for those people. But if people who've been exposed to blood clot or have high risk are interested in giving themselves some symptom relief, they have choices. So there are forms of estrogen. This is a gel, this is a spray that you apply to your forearm, and there are multiple different types of little patches that you wear on your skin that deliver low dose natural estrogen, the 17-beta estradiol estrogen that always came out of your ovary, your whole reproductive life, directly to your blood without going through the liver, without affecting your clotting proteins, without affecting... Now, could you get another thrombosis? Of course you could. Everyone who's had one could get another because you've got issues, you've got damaged veins, you might have congenital, an inherited risk, but that risk does not go up if you choose to use one of my estrogen products. And as Anne-Marie will tell you, that's a lot of what we do in our clinic, is advising patients and giving information. Our frustration is they go back to the GP or the hematologist and they're told, I don't think so. like with no science behind it and no, well, show me the study that you're using to contradict the doctor who specializes in blood clots and menopause. They don't feel the need to do that. So there are amazing consensus statements out there amongst both hematology societies and menopause societies to say, these are the rules. HRT does not cause blood clots so long as you be careful about the route of administration. Don't swallow your estrogen, rub it on, stick it on, spray it on. Your risk of future blood clots is the same as it always was. And this is just all the science behind that. Those are all the green highlighted ones are the names of products you can buy in Ireland with a GP's prescription or one of my prescriptions that will have no impact on your risk of blood clot. Now, unfortunately, the data only supports the use of gentle low doses. So anytime we go above 50 micrograms, we really aren't sure what we're doing. But most people don't need to go above 50 micrograms unless they're very, very young. And for those ladies, we watch them much more carefully. Products like Femitab, Famoston, Premarin, that's that pregnant horses' urine estrogen. That's still very popular in Ireland. If you want a blood clot, that's the pill you want to take, you know? So we avoid them like the plague. But the gels, the patches, and the sprays in low doses are perfectly safe. Women who use estrogen and have a womb must always take progestogen because estrogen causes extra bleeding, and we need the progestogen to balance that impact. And they've done a big study. Yana Vinogradova did a big look-back study that was published in the British Journal of Medicine a couple of years ago, showing us which progestogens are the safest, okay? There's a lovely, I looked on the Irish Thrombosis, but I couldn't find it, but the UK Thrombosis website has a clot leaflet for menopause, and it is bang on accurate. And it specifically addresses the safety of non-oral HRT and the fact that there's no reason on earth why you can't use it. The only thing I will say is the societies recommend that rather than have the GP start you off, because it is quite nuanced, the different progestogens, the different strengths of the estrogens, the different delivery route, that you should see a menopause specialist first, just to become established on the products. Make sure you're getting good symptom control. Make sure you're using the high quality stuff that's not going to affect your risk of blood clot. And then once everything is happy, you can then be handed back over to your GP. Well, that's all well and good for the UK to tell us that. Until about 9 months ago, we didn't have any menopause specialists working in public hospitals in Ireland, but we do now. So I got funding, thank you very much, Stephen Donnelly, from the National Women and Infants Program to set up the first menopause specialty service in the National Maternity Hospital. We opened the doors late November last year. We didn't get our nurse head of operations until March, so we've been sort of playing catch up for a little while. So we now take referrals through your GP from anywhere in South County Dublin, Kildare, Wicklow, Wexford, and Kilkenny. That's our catchment area. My colleague and friend Caoimhe Hartley opened up her Rotunda specialty menopause service this week, and she's taking patients from the northern counties and North County Dublin. And one of the biggest things we see in our clinic is venous thromboembolism. Okay, so those are the reasons why, those are the, what we call them, the referral criteria. We won't, it's not a case of, oh, this lady is having hot flushes, send her to Hollis Street. It doesn't work like that. You need to have been diagnosed with a disease or a condition that makes it trickier for a GP to manage your menopause in general practice. And the number one referral thing is venous thromboembolism. So we have loads of ladies that we've spoken to. And as I said to you, we love meeting them. We're very confident about how to manage their menopause, give them advice and care for them. The stumbling block we realize is that when they go back to the GP who might have to rewrite their prescription on the medical card form or maybe have a review with the hematology team, they're looking at this going, I don't think so. So we need to all be on the same page because that is really disrespectful to patients to get one piece of advice from one specialist and a completely conflicting piece of advice from another specialist. Another big part of what we do is breast cancer, patients with breast cancer, and you'll see that there. We just audited a couple of months of the ladies that we saw. We met 30 ladies who had a confirmed diagnosis of venous thromboembolism. To a woman, we prescribed HRT. I would say half of those ladies never started it. Because if you read the information leaflet in the book, in the box that comes with this stuff, it says, do not use if you've had blood clots. So what are you going to do? Not only are we in conflict with some of the specialists and some of our GP colleagues, we're actually in conflict with the damn lawyers who write the inserts that go into medication. So it's very, very frustrating, and I feel the pain of it. But I mean, like you were saying, it's politics, it's not medicine, you know? So that's your job, Amory. Anyway, thank you very much for your time.
Thank you so much. That was absolutely fantastic. Has anybody got any questions? No questions.
Just here. Just in the front.
Have you any clinics in Cork?
I believe the Cork, the Galway, and the Coombe clinics are due to open next year. They don't tell me much, you know, but they have had the money available for them to take it and hire people and start seeing patients for over 6 months, 9 months. They haven't done it yet. So I'm not sure what the delay is. I couldn't wait to get going. I was doing it for free before I signed the contract because I was so excited to see people, you know. But I think hopefully by the end of next year, we should have 6 services that take patients from every single county. Yeah. Some people who have money will go to a private menopause expert and get good advice from them, but that's a lot, you know, that's like 200 euros for 40 minutes, 45 minutes. That's more than most people can afford, you know. Our service is completely free, obviously, because it's part of the HSE. Yeah. Thanks for that question. Anybody else? Yeah. You know what happened is because we were the only ones for the longest time.
Sorry.
Yeah, unfortunately.
Is there a waiting list?
Yeah, so there is a waiting list by us in Hollis Street. Now we're hoping, I had the pleasure, honor of going on TV earlier this year, and that actually kicked the waiting list in the butt. Like it went nuts so for people asking their GPs for referrals to the clinic. So what I've been doing these last 6-8 months is, if a GP writes to me from outside of my jurisdiction, I say, I'm really sorry I can't see your patient, but here's what you can do in the meantime. So I'm trying to help them along. If somebody's had a blood clot, they really do need to speak to a menopause expert. And obviously if they're not in my catchment area, I can't take them. But if I can take them, the wait is about 4.5 months. But we think I think it's going to be a bell curve. I think it's peaked because of the stupid RTE television thing, and that hopefully by next spring it'll be maybe 2 months, 2.5 months. That's my goal. Yeah.
Thanks.
Happy?
Are adult children more at higher risk?
Yeah, that's a good question.
Sorry, thank you.
Yeah.
Mary is my name. Are adult children of, for example, I've had blood clots.
Yeah.
So would my adult daughters, would they be
Yeah,
at higher
particularly
risk?
unprovoked blood clots. So if your blood clot couldn't be linked back to a particular event in your life or a surgery or a medication or whatever, you have to wonder what was the issue. Was it a physical anomaly, like Dr. Moriarty was talking about with those MRI pictures, or did you inherit some kind of clotting disorder? And the problem is we don't have tests for every known form of clotting disorder. So you might have a thrombophilia screen and it come back clear. Does that mean you're not at risk of a blood clot? No, of course it doesn't. So it's actually quite messy. So what I would say to any first order relative of someone who's had an unprovoked clot, this would be a daughter, a sister, mom, is don't go on the pill. There are so many excellent ways to avoid pregnancy without putting estrogen in your body. Why take the risk that that's going to launch your first blood clot? There's no need for that. So that's, with regard to HRT, the same advice would apply. Avoid the orals, go for the low-dose transdermals, the sprays, the patches, the gels. Yeah.
Thank you.
You're welcome.
Just one big thing. My mum, when she was pregnant, had a clot, and part of me having a clot is the pill. So
Yeah, so that's a no-no for you guys.
no,
Yeah.
but I should have never been. So
No.
why would that have happened? Like, how is that missed? Like, how is it missed if someone knows that this person's mother? You know, sorry that you can't answer this, but it's so frustrating.
I wrote a guide years and years ago with some colleagues on how to prescribe the pill. okay? And it's actually been created, a pharmaceutical company spent some money and turned it into a flip chart that sits on the desk of almost every GP in Ireland. And it says, the most important part of a pill consultation is the history. If this person in front of you has close relatives who had a hormone-provoked blood clot, they should never be prescribed a pill, patch or ring.
My mum was pregnant, and like it's now that the HSE are doing stuff, actually giving young women the pill.
Oh, it's
That is
free
really
now,
weird.
yeah, yeah.
Are they being told?
Well, the rules are the rules. You got to, but you know, the doctors and nurses and prescribers have to read the book. Yeah, and that is a problem for some people. You know.
Thank you.
That is a rookie mistake.
Oh,
that should never
it's
have been
actually
done.
frustrating.
That should never have been done. Yeah, it's like a lady I met yesterday. She's like, I said, how are you getting on with the HRT? She said, you know, it's okay, but I have other issues. And I said, what happened? She said, I went into the hospital for A, B, and C, and I had a red thing on that said allergic to penicillin, and they gave me penicillin. And I just thought, you know, I get it. We're under pressure. Like, there's a lot of work out there and not enough doctors, but sweet baby Jesus, you know, she's wearing a bracelet. Like, yeah, anyways. So stuff happens, and that was unfortunate, and I apologize on behalf of the profession. Jesus. Anybody else? No. Thank you very much. Thank you.